Hey folks, welcome back to another episode of the Change Physician Podcast. This is your host, Dr. Kevin Cuccaro, with my co-host, Dr. Melissa Cady, and today's wonderful guest. This is Dr. Michael Hochman. Dr. Michael Hochman has a podcast called The Healthy Skeptic MD, where he covers some very, very interesting health challenges. It really goes into the data, information, and how to make healthy choices about a lot of these things, whether you're a patient or you're a physician. And what we're going to do today is talk to Dr. Hochman about his background. How is it that he decided to go into medicine, any of the challenges or struggles that he faced, and then how he's kind of incorporated his practice and brought in this media aspect with the Healthy Skeptic MD podcast. So, hey, Michael, it's great to have you on the show today.
Well, thanks, Kevin and Melissa, for having me. Look forward to our discussion.
All right. So let's start at the beginning then. You know, we've kind of led to where you are now, but why is it that you even chose to go into medicine? What was the kind of background there?
Yeah, I wish I had an exciting explanation for that. It was as simple as I liked working with people. I was interested in science. There were some doctors in the family, and it just always seemed like an interesting thing. You know, I remember taking some science classes in college, and there were a couple my friends who were sort of feeling pressured to go into medicine. And they said, but Mike, you actually seem like someone who would actually be a good fit for this profession. And in some ways, I was hearing that from someone else. And I said, maybe this is the right direction. So I certainly have no regrets about going into medicine in general.
Great. And what were your experiences then when you went into medical school? I mean, you had a background where you have physicians in your family. So did that prepare you? Were you, oh, I know exactly what's going on? Or once you were in the lived experience of it, did that sort of change your perspectives or say, maybe this is a little bit different than I thought it might be?
Yeah, well, I'm sure it's always, even for people who have it in their family, and certainly in my case, it was different than what I expected. You know, the first 2 years are just classrooms, but what really struck me is when I got into the hospitals my third and fourth year, that it seemed that medicine was not as much about the patient's goals as it was about the doctor's goals. And I just remember sitting on internal medicine rounds that would go on for hours and hours and having these discussions that I couldn't really connect to what was actually the patient's problems. And, I sort of scratched my head and said, this is a great profession. I just got to get through this training. But I certainly remember hitting that slump in medical training where I sort of asked the question, why are we here if we go off on all these tangents that are about us?
Yeah. I was going to, one more thing here. Then did that lead into your decision to go into primary care then?
It did. Well, I definitely remember feeling frustrated and a little burned out in medical school. I decided to take a year off, part for my mental health. And, also I thought it would be good to see something different. So I spent a year in the Indian Health Service in the Navajo Reservation in New Mexico. And it was just a wonderful experience, in part from just seeing that there's a world out there that's not academic medicine. I saw family medicine doctors on the Navajo reservation who were providing care at a level that some of the specialists that I was at working with in Boston were doing. So they were treating hepatitis C, which in Boston was, of course, something you need to refer somebody to. Just being out in the fresh air and just in the outdoors and how important that is. And it really sort of re-energized me. I think it also showed me that the systems of care can be very effective. In academic systems, the research is a big driver of things and the education, but I had never really seen a functioning system work like that. And that's not to say that the Indian Health Service is perfect by any stretch. And so I think it really shaped my decision to go into primary care, working with safety net populations and do some of the systems work that I've done.
Awesome.
Wow. So it seems like when I try to think of what was different, obviously there's no place that's perfect. I think all of us know that. But at the same time, the value, I guess, what was it that you felt? I perceived almost as like there's an opportunity for more relationships and interacting when you're on the reservations versus like in academic medicine. Did you feel like there was just a better opportunity to connect with people that value things or value different things? I know that's like kind of a general question, but it seems to be that when you can slow down and actually engage with people in a humanistic way, that's where the sweet spot is.
Yeah, I think that is definitely a part of it, but for me, it almost seems more simple than that. The doctors that I was working with in the Indian Health Service, they were really having fun in their job. I had one attending physician who would go out to the uranium mines, and he would drive a couple hours and do interviews of former miners to document some of their the health consequences for that. And it was really about a passion for what he was doing. And he loved being in the outdoors in that community. And just the varied experiences. They would do help out with a C-section, and then they would be in the ICU and then doing a vasectomy. And it just seemed fun in a way that what I was experiencing in academic medical centers wasn't. And I think you're onto something as well, that they really felt that it was a population that appreciated that they were there. And it was really about doing things for the right reason.
Yeah. That variety seems like a big part, and a change of environment instead of the four walls of academic medicine that's, I think, can get old.
And as a tangent, I just think that that's one thing that's so important for clinicians to be happy in their career, that every day is a little different, that there's a new challenge, and it's not just the same thing every day.
Absolutely.
So,
Kevin?
So then you got involved when you went into residency, or actually when you call yourself a recovering health journalist, oftentimes in your introduction on the Healthy Skeptic. So how did you fit that into this picture of physician and now health journalism?
Yeah, so I came back from working on the Indian Health Service for a year, and I actually had a couple extra months and some credits that were built up. And so I had always had an interest in writing. I wrote for the school newspaper in college. I was actually a sports writer. And so I reached out to the Boston Globe and asked if I could do some freelance writing, and they were actually in need of some freelance writers, which I really enjoyed doing. I think it was very clear I was not going to be the next Atul Gawande. So I decided it made sense to go back to med school and finish that up. But I've always had an interest in communicating and trying to communicate complex medical information to a broader audience.
So then leading into that is for a project before the Healthy Skeptic was updates in slow medicine. And could you just briefly describe what slow medicine is and how that relates to primary care?
Sure. And actually, this relates a little bit to what I was describing before when I was saying I was in the hospitals and I was asking the question, why are we here? So I saw maybe one example is in older people who were towards the end of life, and we were pushing invasive procedures on them, which just couldn't imagine. I couldn't imagine that they were advancing their goals of care. And then as I learned more and more in my medical training, I saw so many of the things that we do in medicine, maybe they have certain benefits in certain populations, but the way that they're implemented in real world practice, it just did not strike me that was actually adding value for anything. And I had an attending physician when I was a resident in primary care, Dr. Peter Cohen, who was always pushing me on this. And we kind of, got into these issues, and we realized we really saw things very similarly. Peter actually coined the term slow medicine. We do have a stodgy definition of it somewhere, but I think probably a simpler way to put it is just that, there's forces of aggressive care in healthcare, and there's a less is more philosophy, and that things are shifted too far in healthcare to the aggressive interventions that we do. And slow medicine is sort of reminding ourselves that sometimes a wait and see approach is actually just as good as doing something, even if that's what we're urged to do at the minute, at that particular moment.
Yeah, it makes me think of just being mindful and thoughtful and appreciative of the body's capacity to heal, like all of those things combined. Would you agree with that?
Yeah, humans have had however many hundreds of thousands of years of evolution to evolve, and that we think that this new pill that we have is going to fix things like a magic bullet, is to have some humility and realize that we only want to use these interventions when they're truly proven to work and they're going to make things better for the patient.
Yeah. Well, go ahead.
Well, I guess because I'm going to intersect this with what you do with healthcare systems then, because you have an interest in the delivery of healthcare and healthcare systems and an interest in slow medicine and kind of aligning that wait and see attitude, or not attitude, but really approach, which makes sense. But for many healthcare systems, that slow medicine approach is foundationally not aligned with how the system delivers care. So I'm kind of, how we've been navigating that sort of conflict there.
Well, I think the overlap in those two areas of interest is, the bureaucracy always drove me crazy in healthcare, and I know I'm certainly not alone. But we doctors are pulled in so many different directions, whether it's these EHR systems that were built for billing purposes and not for documentation's sake, or whether it's regulatory requirements that maybe there was a good reason once for them, but when you put it all together, it's totally mind-boggling and probably counterproductive. So, in my mind, it's sort of so my interest in health systems. How do you push out the noise so that we actually can use our time for the things that make sense, that whether it's the healthcare interventions that really make a difference for a patient, spending the time with them, and we're not spending our time doing the administrative nonsense.
Mm-hmm.
Yeah. I went a little tangent here when you were talking a little earlier about how sometimes not just convincing the systems, but even the patients to have an appreciation for the body's capacity to heal and have patience. I think there's a, how do you sell that and try to, I don't want to say convince, but in essence, we have to try to persuade people to think of their bodies differently and think of medicine differently. How do you kind of deal with that issue?
Well, I actually think, and I'd be curious on your opinion on this too, that a lot of patients are actually looking for that. And we spend our whole time persuading and convincing them that this pill that we have for them is actually going to be more effective than their own body's healing capacity, or letting time do its thing. And that patients are so happy when they hear an open-mindedness to alternative approaches. Now, there are certainly patients who don't have that mindset. And I actually am more okay with that when it's driven by the patient. But what always bothered me in medicine is when we were talking patients into things that really didn't seem to make sense to them, but we just kept hammering that this is what you need to do. And that's what Slow Medicine and our Healthy Skeptic MD podcast is trying to do, is to show people there's another way.
Yeah. Well, and the infrastructure needs to be in place too, to value good conversation and guidance versus doing something to a patient. So Kevin, I know you were going to say something.
I was going to agree with you there, because it's then you're going to this conflict with what, you were talking about, Michael, where you want to listen. And I think a lot of physicians actually want to listen to their patients and want to spend time to them, but you're in many ways penalized to do so. When you have the EHR and 42 click buttons, and then the IT tech tells you, well, we just did an update and it's just one more click, it's just one more click on the top of 10 other clicks that you have to do. So that's how do you keep yourself sane? Because you're definitely in an academic environment and you're sort of in the thick of things when it comes to medicine. How are you adjusting to that? Like I know you kind of briefly mentioned about getting rid of that administrative burden, but have you seen some structurized approaches or things that you guys have initiated at USC around this kind of idea?
Well, for me, it really is because of that variation in what I do. I see patients a third of the time, and even that's broken up between some outpatient medicine and some inpatient medicine. And then I do a little bit of research, and then I'll do the podcast, and then I'm on some policy committees. I think if I did any one of those things all the time, I would absolutely go crazy. And I think, I'm much more patient in these meetings when I know that I can actually go and see a patient and directly help them afterwards. So even if it was a frustrating meeting, there's another thing to do. And then I think, like, by the same token, if I was seeing patients and documenting notes all day, that would really be a burnout. I think it's very hard, for many of my colleagues, and there certainly is a lot of turnover in academic medicine. And, I think to your point about why did doctors go into concierge medicine? I completely understand it. It's a way to be able to have that connection with a patient that's not possible, sadly, in our current system. That's not the right model for me, and probably not, you're not going to be able to take care of an entire population that way with concierge practice. But I absolutely understand the desire of doctors to have that type of connection with patients.
Yeah. Now I'm curious, I know we've kind of taken you from that beginning desire for medicine to where you're doing things now. Is looking back at all of the things that you've done, what do you feel is like been the most rewarding? And maybe kind of restating some things, but what's the most rewarding thing that looking back on it, that you've done or created, or just in general, like where you're at now, what you enjoy the most?
Yeah, it's an interesting question. Funny enough, I think it's probably the simple things. It's, I love doing the podcast and I think that's going great, but it's sometimes those individual interactions with patients where you kind of go the extra mile and they really appreciate it. But probably along those lines, it was the simplest intervention that I've ever done that's probably had the biggest impact. So when I was just finishing my fellowship training, I worked at the county hospital here in Los Angeles, and no one answered the phones. Literally the phone would ring and, 80% of the time, no one would answer it. And, if they did, they'd put you on hold. So patients had no way of getting in touch with the doctor between visits. They had a problem with the medication. Find out, you can follow up 3 months later. There was no recourse. And sadly, that's true in many safety net systems. And so I was a clinical scholar, Robert Wood Johnson Fellow, clinical scholar at UCLA, and we got a grant. And we did the very simple thing of created a call center to 2 unlicensed care coordinators. And all they did was answer the phone. They spoke English and Spanish. And that almost doubled the patient experience scores, the CAP scores from patients compared to the control clinic. Wasn't some fancy digital innovation. All it was someone answering the phones and carving out some same day visits.
It's awesome.
That's awesome.
Yeah, I know. Yeah. I love it. It's like people are like, trying to do these moon launching things or whatever. And that one seems like, oh yeah, a call center. That actually makes a lot of sense. Why don't we have a call center? But,
yeah. Communication. It's a key to a lot of, happy patients. And I can say from some of the things that I've been doing that, just feeling like you're not going to have a stop where suddenly, it creates a frustration on top of whatever issue or pain that they're having. So I applaud you for even thinking of doing that for that kind of project. That's a great way to.
Well, it's a great fellowship project. I think projects like that are just so operationally challenging. It's, I could never do it in my current practice. That's that's more of an operations task. But I think that's why it's so important to have physician leaders, because I think when we don't have that clinical voice in there, administrators, and they're well intended, but they don't focus on the things that really make the simple things that really make a difference for patients.
Sure.
So where I was going to say was where then with Healthy Skeptic MD, which you started last year in 2020, which is an interesting time to start a new podcast.
Maybe spending a little too much time on the computer at home.
So what are your goals then with Healthy Skeptic MD? Who's your audience and what is it that you're trying to deliver with that program?
So Peter and I did updates in slow medicine for about 5 or 6 years. That was targeting a healthcare audience, just highlighting new research studies that emphasize the less is more concept. We had a great time with it, but I think we realized that in order to reach or to have more of an impact, we wanted to touch patients directly. Peter's been very busy. He's become like truly an internationally known researcher in supplements. He would actually be another great person to interview for this podcast because he's had a very interesting and varied career. But I decided to continue on this, but shift to a podcast format and with patients. And so that's exactly what we try to do. We try to talk about common key decisions that anyone might need to make at some point in their life: cholesterol medications, cancer screenings, getting prenatal screening for obstetrics situations, and just try to distill it in a way that patients, again, know that there's multiple different ways of doing things. Everyone doesn't have to do exactly the way the guidelines or their doctor tell them, that there's alternative approaches.
Oh, that's great. I love that.
Makes me laugh a little bit because you touched on these things, and as a patient, they may, well, what's controversial about cancer screenings? That seems to makes perfect sense. We should just do all these screenings all the time. So anyway, you guys, if you're interested in that, you should definitely go to the Healthy Skeptic MD and check out that episode, because that's a very important decision to make, one that you should be fully informed on. So
yeah, I was going to mention, is there anything upcoming? I know this is just kind of a continual flow of your podcast releasing, but is there any place you'd like to direct people on things that are coming up, or just where to find you or learn more about what you're up to?
Right. So this season, the website is healthyskepticmd.com, and that has all the latest episodes. This season, I'm focusing on key common medical decisions, pros and cons of cancer screening, cholesterol medications. We did one last week on alcohol as a daily glass of wine. Helpful. Next season, I'm going to focus on emerging technologies. Is genetics going to revolutionize medicine? And, what should our expectations be for that? So some more sort of looking to the future type issues. And we'll just sort of go from there. As I'm really doing it to have a good time and have interesting conversations and hopefully educate patients in the process.
Perfect.
I think that hits a common theme that has been coming up over and over again with this, is your love of variety. I went out on the Indian reservation and he did all sorts of stuff. I'm like, oh, that sounds like a lot of primary care docs where they want to do everything. And then you're like, well, in my practice, I can't just see patients all the time. I have to be involved in this, this, and this. And there's some variety. And I can't think of anything more that would give you quite as much variety as a podcast could potentially do. So I think that fits very well with your mindset there.
My ADHD mentality. But I have to say that's, I think, a lot of the challenge that a lot of doctors run into, where they really want to do something, and sort of the mantra in academic medicine is know more and more about less and less, and get narrower and narrower in scope. And absolutely, it's great for people who want to do that. And that's how you probably advance science and come up with the next discovery, is stick at the same issue for 30 years. But that's not the right way that all of us can contribute.
Yeah.
Absolutely.
I agree. I ran out of room, all different things to describe myself on my Facebook page. I said, I love a little bit of everything. That's about all I can say. Kevin, any last questions before we finish off?
No, I don't think so. Thank you very much, though, Dr. Michael Hochman, for coming onto the podcast today. It was great talking with you. Love to hearing your physician's journey. And then I'll let Melissa take it out with her fabulous voice here.
Oh, I don't know about that, but thank you. Well, for those of you listening, I am Melissa Cady, the Challenge Doctor, with my co-host, Dr. Kevin Cuccaro, and our guest honestly brought in the importance of variety, as we just mentioned, but also taking it to not just patients, but educating systems, other colleagues about a lot of important issues that we should be talking about. And I appreciate your time, Dr. Hochman, to join us on The Change Physician. And make sure to check out the show notes to find him and all the things that he's been doing. And until next time, you all take care. Bye-bye.